Now, we're sitting here talking about rare diseases. We're on television. Of course, the new age is that everybody talks about everything in public all the time. Patrick, based on your experience, have you witnessed a shift in awareness and advocacy for these diseases?
I think it's important that patients with hemophilia have access to specialized care and also the medicines that they need. But since it's such a rare condition in terms of population statistics, I think it has been helpful that individuals with hemophilia have banded together to advocate for themselves and for the disease. And physicians certainly partner with them in that, in that effort.
Now, how have policies then, I mean, if I assume what you're implying is that by partnering and by advocating, we're going to get policy change, we're going to make people do things to help us as a group that they might not have done before we got together and did this. So how have policies and regulations evolved as a consequence?
Well, the policies, I think, have evolved in terms of access. I mean, the role of managed care is to provide access to appropriate drugs. And that, in many cases, involves a prior authorization to ensure the diagnosis is there. It also involves sometimes formulary management, so not everything may be preferred. That does have implications for sometimes cost share, what the patient's going to have to face. But in general, we're talking about hemophilia. These products in general are available. I think what we don't want to see is bleeds, because that has very significant consequences in terms of hospitalizations and cost, and that's what we're all trying to avoid.
So it sounds like you're doing a balancing act.
Absolutely.
The drug may be expensive, but the consequences of not taking this drug may be more expensive. And are payers aware of this, and are they dealing with this every day?
We're very sensitive to that. These are by far not just because of blood product, but also the consequences of a bleed. You may end up with in a hospital for severe bleeding, and that has very, very significant cost. It also has cost in terms of the long-term implications for joints. The bleeds cause joint damage. Ultimately, these patients have difficulty in function, but they may also require joint replacement.
So, when you talk about this, and when you talk about advocacy, what you're really talking about to some degree is legislation. Because at some point, if you can affect legislation, you affect policy. So there are two big pieces of legislation that I think we need to nail down. One is the Orphan Drug Act of 1983 and the Rare Diseases Act of 2002. Who wants to help me out on this? What are these things? What is the orphan drug class here? Can you help me with that?
I think the general philosophy, especially in hemophilia, is that these drugs are made available. The challenge is sometimes with, sometimes their inappropriate use, and I'll mention recombinant, which is sometimes used in hospitals, where you may not have a true hemophiliac, where you're significantly adding to cost and where there are other options. I think the challenge is also sometimes to make sure patients have access to hemophilia centers of excellence and make sure we channel patients to those centers of excellence, because that's where they're going to get the best care, a team approach, coordinated care. And again, the goal is to minimize bleeds.
But I want to back up. This is how you're reacting to this legislation, but let's get first principles on the line. What is the Orphan Drug Act? What does it say? What is the Rare Diseases Act, if somebody can help me out on this? And then what are the circumstances that prompted these, and what is the significance now that these are in place? Anybody want to help me with this? Hugh, can you?
Well, with a lack of, we talked about rare diseases. Again, the prevalence being about 25 million people in the United States. However, only a very small fraction of these disease states actually have approved treatments. So we still have very significant unmet needs. And given that the numbers of people with this disease states are very low, at some point in time, the economic value was not there for pharmaceutical companies to spend a lot of money on R&D to bring drugs to fruition to treat this disease state. And that's where Congress then stepped in to provide the incentives for pharmaceutical companies to research and to bring products to the market by giving both tax incentives, grants that could be used in development of these drugs, and also the exclusivity for these products that also motivates pharmaceutical companies to be able to develop these drugs get the investment back, and also be able to make a profit.
So if I understand you correctly, if something is declared an orphan drug, that is a drug that is designed to treat X number of people with this disease, which is less necessarily than might be economically advantageous for a large pharmaceutical company to do otherwise. And they get benefits from the government for this orphan drug. And those benefits include what? Exclusivity.
Exclusivity, pricing, a 50% tax benefit on the cost of the drug development. There are also grants that are available through the government agencies such as the NIH that also helps in defraying some of the cost of development. And also we mentioned exclusivity, which is a big one for this company. Also another incentive that the legislation puts in place, it waives the user fee that the manufacturer has to normally pay when they file for an NDA. But in the case of orphan drugs, that user fee is also waived. So there are tremendous tax incentives. There are tremendous market protection also as far as exclusivity that has been put in place that again to incentivize manufacturers to research and to bring drugs to the market, given again that we still have a significant unmet needs as far as the number of disease states that fall within this category that do not have approved treatments.
What is this Rare Disease Act as opposed to the Orphan Drug Act? Can someone help me out on that? And since nobody can, let's keep going.
Well, let me give an example that lupus is not a very rare disease. It's 350,000 people. In lupus, the new drug development is really because the market is there. Since the rheumatoid arthritis market has become somewhat crowded with biologics, I think industry on their own decided that development in lupus was something that was important for them, and then of course for our patients.